Dr. Dawson is a graduate of the University of Southern California School of Medicine. He does general and vascular surgery training at the University of Washington. He was in the United States Air Force and served at the Air Force Medical Center in San Antonio. He actually applied to the Space Shuttle program and just barely didn't make the cut to be a mission specialist, but NASA was impressed enough to bring him on as the medical director for the Space Shuttle program, which was a job he had before we successfully recruited him here. He's been on our faculty here now for more than a decade. I think probably most of you guys have had a chance to interact with Dr. Dawson. He's going to speak to us this morning about ultrasound for surgeons. Dr. Dawson.
Thanks, Bill. So ultrasound for surgeons by surgeons. No financial disclosures related to this topic, but I do serve a number of organizations in a leadership role, but I'm presenting today as an individual, not representing any of these particular organizations. So what I'm going to do is talk about some of the history of ultrasound, how it developed, and some of the key concepts. We'll talk about some of the principles of ultrasound imaging and the modalities used by us as surgeons in clinical practice, perhaps with a little bit of focus on the vascular. The technology is changing, and point of care is no longer the future, it's here. We'll talk about point of care ultrasound. And then some of the things that are going on with education, accreditation, certification to help make patient safety better and to provide for appropriate use. And we'll highlight some of the things that UC Davis faculty and residents and technical staff have been doing to help make quality care better. So let's start with history. This is actually the first use of ultrasound. It was early in the 17th century with a point-of-care system. Actually, that wasn't a real picture. The earliest uses were non-medical, and they involved the non-visual identification of objects, including the detection of location, movement, composition, and other features. There were a couple of early pioneers in this work, including the bats and the cetaceans. And so the idea of echolocation, when it was first conceived of by a human in the 1700s, was based on some observations of animals. Spallanzani was a Catholic priest and biologist and physiologist, and he was best known for kind of debunking the idea of biogenesis, that organisms just kind of appeared, that there was biogenesis, they didn't just preform and just appear, and this concept was, the old concepts were subsequently discredited by Pasteur, but he did experiments in the late 1700s that demonstrated the ability of bats to navigate accurately in the dark and proved that it was from echo reflection of inaudible high-frequency sounds. And so sounds that are above the frequency of the human threshold for hearing, which is, that's right, 20,000 hertz, is what we call ultrasound. So anything above 20,000 hertz is ultrasound. For humans to make it, we had to use technology, and the way that we make ultrasound is with the piezoelectric effect. An electric potential produces a mechanical pressure, or an electrical potential is created when a mechanical pressure is put on certain types of crystals, and when there's a mechanical stress applied to these crystals, that it produces a voltage. And this effect allows for the generation and reception of ultrasound in the megahertz frequency range. So when did this come about? It was actually discovered by the Curie brothers, Pierre and Jacques. Pierre was Madame Curie's husband, and they found that crystals moved in response to an applied potential, and there was subsequent deduction that the converse was correct, or would happen, and there was further research and development in piezoelectricity. It was actually one of Pierre Curie's students, Langevin, who had the first applications of this in what we would call perhaps a modern concept involving ultrasonic detection of submarines and prevention of collisions at sea. So it was both a maritime safety and a military application. And he knew that you could create an echolocation system based on the time of travel of a sound pulse to a submarine, and the return time through the water could be used to to calculate the distance. And this is what we call sonar. Now, sonar was first used in the early 1900s, and it was a part of the military tools of the First World War. And it is an important part of military and commercial applications at sea. But now you can get highly sophisticated sonar for only a few $100s from Garmin and put it on your bass boat. But it turns out that even these sophisticated sonars are still not quite as sophisticated as what the Navy uses when they train cetaceans, marine mammals, to do pick up targets in a harbor in a muddy field. They can find things that can't be found otherwise. Now, ultrasound in medicine came about in the mid-portion of the 20th century, and the earliest applications were therapeutic. Ultrasound with vibration causes heating of tissue and can cause disruptive effects. And so it was first used therapeutically as an ablative technique in neurosurgery, and then as a therapeutic tool in physical medicine. And when the American Institute of Ultrasound in Medicine was formed, it was really about therapeutics, at least until the mid-1960s. The concepts of medical diagnostic ultrasound were first popularized, or first discussed, by an Australian neurologist, Dawson, who published a paper in 1942 on medical ultrasonics. But Professor Ian Donald of Scotland was really credited with the first practical technology for ultrasound imaging. And Donald was an obstetrician gynecologist. In World War II, he'd been a medical officer in the Royal Air Force, and he'd become aware of the concepts of echo sounding and ranging with anti-submarine actions of the RAF. Well, in terms of surgical disease, the first diagnosis of surgical disease was credited to George Ludwig, who published a paper in 1949. It's actually embargoed for a period of time because it was thought to be sensitive military technology. He did the research as a naval officer, and he used ultrasound to diagnose the presence of gallstones. He used a technique called amplitude modulation, or A-mode, where tissues were pulsed with ultrasound, and the echo return was displayed on an oscilloscope. The oscilloscope tracing would look something like this, with a peak as the echo came back from different tissue interfaces, and it was relatively difficult to interpret. In the 1960s, we started to see what was called B-scan, or scan converters that would create images on cathode ray tubes, TV sets, as opposed to an oscilloscope, and they had a fairly limited dynamic range, and pieces of a scan would be patched together to make something that looked like a picture. By the 1970s, these were combined in what was called a single B-scan picture. Now, we use something like this now, what we call B mode or brightness mode, where grayscale is used to display in a pixel the amplitude of an echo, and this builds a 2D picture or slice, and the pixel brightness is related to the amplitude of the echoes being received from the interfaces, and the depth is calculated by the time between the pulse and the echo, knowing the speed of ultrasound in tissue. This is the basic concept behind ultrasound imaging. Now, we also use Doppler. The Doppler effect was described by Dr. Effect, actually Christian Doppler, who was an Austrian mathematician and physicist. And he described this in a paper that explained the color of binary stars. There'd be movement and there would be a phase shift in the light. And this principle was adopted to measure speed of movement or flow. The first commercially available instruments used ultrasound with the Doppler shift to detect movement or flow was the SmithKline Doptone here on the upper left. And it was initially marketed as a device for the detection of fetal heart tones. It was a way to check on fetal viability and listen to fetal heart rate. But other instruments came along, and these were part of the kind of the 1960s and 70s development of the vascular laboratory. The vascular laboratory at that time was focusing on these non-invasive tests that looked at pressure or changes in the volume of a limb. And they did that because the early ultrasound systems at the time lacked the resolution for vascular details. And the pioneer of these types of tests was Gene Strandness at the University of Washington, and he's also credited to adding the Doppler to the imaging to create what we call a duplex scan. And this is the prototype duplex scanner from the Strandness laboratory, where it is physically bolted on. The Doppler ultrasound is bolted onto a scan head and used to evaluate the carotid artery. Now, duplex scanning has evolved in its technology and its applications, and currently it's broadly applicable for the evaluation of vasculature and perfusion in almost every organ system. There are a number of advanced imaging applications, and we don't have enough time to go into all of them, but we can use intravenous administration of ultrasound contrast agents. We can do 3D, 4D imaging to create pictures that are quite lifelike. Or we can characterize tissue by the movement of the tissue in response to the incidentating ultrasound and do strain gauge elastography to detect the difference between tumor and non-malignant tissue. Turns out we were beaten to the punch. So dolphins are able to, with their eyes closed, do all of those things. So this is my daughter. She's actually the one who has the hair. She works with marine mammals, but she told me about an occasion where they had a younger dolphin who was doing an encounter with a visitor, and the dolphin was quite bothered by this particular visitor. And one of the more experienced trainers knew to take that dolphin out, and they put the old lady in, a retired Navy dolphin who had been around. She was blind because of her cataracts, but she was pretty calm about things. Turns out the young dolphin was a little bit upset because he recognized that there was something amiss. The person who was in the water had an artificial heart valve, and that didn't sound right. So they're very, very quickly able to detect what was right and what was wrong. Well, dolphins take their ultrasound with them. They do ultrasound imaging and tissue characterization at the point of service. We do point of care ultrasound with exams that are linked to specific purposes, focused and goal directed, with findings that are easily recognizable, and an exam that can be learned by people like you and me. Exams that are quickly performed because we have short attention spans and often performed at the patient's bedside. But the bedside can be, well, anywhere. The first commercial point-of-care ultrasound was in the 1970s, and it was developed by an engineer who actually was affiliated with a surgeon. Ted Dietrich was a cardiovascular surgeon in Arizona, and he was working with ADR, Advanced Diagnostics Research Corporation, and they built about 5,000 of these early units, about 25 pounds. It was an oscilloscope display. It wasn't very sophisticated, but that was point-of-care ultrasound. Well, how do we get to point-of-care ultrasound today? Well, like everything else, it takes a little money. And the catalyst for the development of point-of-care ultrasound as we use it today came from the Advanced Projects Research Agency. Now, if you haven't heard of DARPA, they're the folks that make investments in what they see as breakthrough technologies specifically for the military, but for a variety of non-military purposes. And they look for transformational change rather than incremental change. So they do this future soldier stuff. They do materials. They do all sorts of things. Basically, it's kind of like a Tony Stark thing. So DARPA has done a few things you might have heard of, things like stealth technology, things like putting a GPS that's small enough to carry in your hand into the applications that we have now, and in fact, GPS that we can wear on our wrist. And they developed this network thing, the internet. It wasn't actually Vice President Gore. It was a DARPA predecessor, ARPA, and the ARPANET was, in fact, the basis of our modern internet. So DARPA gave money to a company called Advanced Technology Laboratories, say, work on this project. They said, we want a digital ultrasound. It can't weigh more than 10 pounds because, well, you only have a limited amount of room in your pack. It has to boot up in 10 seconds. It has to be durable enough to work in the field. And what they did is they came up with some application-specific integrated circuit technology, made the first real point-of-care system, I think, the Sonosite 180, and they were spun off as a daughter company. Point-of-care ultrasound units now look like iPhones. They look like iPads. They look like laptops. They look like really whatever you need to use. It needs a display. It needs a beamformer. It needs digital image processing technology, and that can have a very small form factor. Point-of-care ultrasound can meet all of the roles of ultrasound that we use diagnostically. Diagnosis, symptom, or sign-based, resuscitation, which surgeons pay a lot of attention to, procedure guidance, which we focus a lot on, and some therapies. There are some barriers to incorporation of point-of-care ultrasound, some resistance to change and established practice patterns. You have to have available training. It doesn't take a lot of training, but it does take training. And you have to have the imaging systems, and then you have to have it fit in to your healthcare system. There's a lot of things that you can see fairly easily without a lot of sophistication. You can take a look at a gallbladder, and you can find it, and you can find gallstones. Someone can come in and have symptoms in a positive pregnancy test. You can confirm very early on. It's an intrauterine pregnancy as opposed to ectopic pregnancy. And it turns out some of these very simple yes-no kinds of questions can expedite care, reduce times in the ER, and they result in significant cost savings, have been shown. One we pay a lot of attention to as surgeons is the focused assessment with sonography for trauma, the FAST exam. This was an exam that was pioneered by surgeons, and it was initially intended to be performed by surgeons. And when performed by surgeons, it actually has good sensitivity and specificity, and it is now mainstream. The American College of Surgeons has incorporated the FAST exam. It's part of the ATLS course. Parenthetically, the college, American College of Surgeons, has been advocating for surgeon-performed ultrasound since the 1990s. When it first became possible to get ultrasound into the hands of the doctor for point of care, radiologists didn't like that idea. They said this needs to be an imaging specialist as opposed to a clinical doctor's tool. The college formed a national create a national effort for education training of surgeons, and has issued position statements and advocacy to support surgeons' access to point-of-care ultrasound. In terms of the evaluation of the old test that I did when I was a resident, DPL, and the one that we use most frequently, CT, there's really a lot of advantages to ultrasound. Non-invasive, rapidly performed, and easily repeatable, and it doesn't require the use of contrast. So it's a nice yes-no to some simple questions of, is there intra-abdominal free fluid? We can also do some other things like assessment of central venous pressure, assessment of the adequacy of resuscitation. One of the things that we find frequently is that if someone is oliguric, they're not making a lot of urine, the response is, give more urine. Actually, they can say, give more fluid. And that's a really good solution to a hypovolemic patient. But for the patient who has renal failure or heart failure, whose volume overload, it isn't necessarily going to help, and it may hurt. So knowing the endpoints of resuscitation can be useful, and assessment of central venous pressure can fairly easily tell you if someone's on the high end or low end. It can't really tell you with a good discriminatory value, where they are in the middle. But there have been a lot of studies looking at simple measurements of inferior vena cava dimensions and collapse, and they correlate fairly well with other measures like CVP or right atrial pressure, and can be used even on intubated patients if they're not getting PEEP. Now, it used to be that I always thought that ultrasound was great in the abdomen and great in the extremities, but not so good in the chest, because ultrasound doesn't propagate well through air. But it turns out there's a lot that can be done, and a lot that is done with lung ultrasound now. And one of the easiest applications to learn is to see this sliding lung sign and find out that that's someone who has visceral pleura and parietal pleura moving against each other. And if they don't have that, they have a pneumothorax. So what I've heard in the past is someone said, well, someone was crashing. I needed to vent the chest because they might have had a pneumothorax. And the answer is, well, you might be able to find out with a 10-second test if that patient has a pneumothorax, and either decompress the pneumothorax or focus your attention on the actual problem. So simple tests at the bedside in resuscitation may have benefit in taking you down one path or another in terms of evaluation and treatment. We do a lot of tests in our vascular laboratory to rule out DVT, but simple tests at the point of care are often done to look at the popliteal and femoral veins to see if they compress with the placement of the transducer. If they do compress, they're not filled with clot, it's not a DVT. And even though this isn't as complete a study, it gives you a lot of information that can help you go down the right path. And also the ultrasound, if you're evaluating someone with leg swelling, can look for other causes of leg swelling, such as adenopathy and lymphatic obstruction, or overall edema, or other things that might occur, like Baker's cysts or muscle tears. In our practice, we use ultrasound to guide interventions and guide access. We do a lot of arterial access, but other people do a lot of venous access. You can do this precisely or imprecisely, and if you don't do it with precision, oftentimes you're just fine. But we found that imprecise access to the femoral artery can create problems, and sometimes they're big problems, and sometimes they mean someone needs an operation. So what we do routinely is ultrasound-guided access, and now in the cath lab, the cardiologists do ultrasound-guided access routinely, and this has decreased the residents' experience with treatment of pseudoaneurysms and groin complications because it reduces complication rates. It's fairly safe and fairly easy, and our residents will be very bad at getting vascular access without ultrasound because they're just routinely doing all of their access with ultrasound safely and effectively. Now, last year at Grand Rounds, I talked a little bit about ruptured abdominal aortic aneurysm. We do imaging of the aorta to look for aneurysms, to treat aneurysms selectively, but we know that ruptured aneurysm is a time-sensitive problem because when we looked at UC Davis mortality from ruptured aneurysms, we found that the mortality from ruptured aneurysm was closely associated with delays in getting to the operating room and getting treated. So to eliminate delays, there was a program that looked at all of the things that might affect the time to diagnosis and action. And we now have a ruptured aneurysm evaluation. It really focuses on early recognition and early activation of key resources. And where that starts, the very top of this chart, is point-of-care ultrasound in the emergency room when someone presents. And it's not just the patient who presents with the classic triad of abdominal or back pain, a pulsatile abdominal mass, hypotension, that's actually pretty easy, but also patients who come in with risk factors and maybe one of these particular classic presenting problems. The point-of-care use of ultrasound is pretty easy for abdominal aortic aneurysm in most cases, but sometimes obesity or the presence of significant overlying bowel gas can make it difficult, and we need the CT to make the diagnosis. But really, when you simplify it, we got this complex algorithm that really starts with identification, communication, and action. Therapeutic ultrasound. I mentioned that the first uses of medical ultrasonics were in therapy. There are some benefits that have been attributed to ultrasound: increase in local blood flow, a decrease in pain, stimulation of soft tissues without strain, and these are due to the bioeffects of ultrasound that I mentioned. Thermal, due to the absorption of the ultrasound energy, and non-thermal, which is cavitation, microstreaming, a little bit of tissue disruption from higher energy ultrasound. The effectiveness of therapeutic ultrasound for musculoskeletal injuries and pain still is not well documented, but there are a lot of therapeutic applications. Things like lithotripsy for kidney stones or gallstones. If you've been to the dentist and had your teeth cleaned, you've probably had an ultrasonic cleaner. We also do ultrasonic tissue debridement. The ophthalmologists use ultrasound for phacoemulsion to remove cataracts. And there are still the same kinds of procedures that were envisioned more than half a century ago with the use of ultrasound as a tissue ablation tool. There are some more advanced things like enhanced drug uptake using acoustic targeted drug delivery. And we use ultrasound to guide interventions such as endovascular treatment of venous insufficiency. We also use ultrasound energy to help deliver drug when we do thrombolysis, and we can connect a catheter to an ultrasound generator where there's an ultrasound piezoelectric crystal on an inner lumen of the catheter that's delivering thrombolytic agents, TPA. which acts to deliver the agent more effectively to the thrombus, to agitate the thrombus, to physically break it up, and decrease the time of treatment. Some other applications of point-of-care ultrasound is a roadshow. You can take ultrasound with you where you go, even if it's not a first world setting. And in global medicine applications, ultrasound has been highly effective at helping with early diagnosis of treatable surgical diseases, and it's been highly effective in reducing maternal mortality. In many areas of the world, there is not access to obstetrical care, but local providers and midwives can use ultrasound with minimal training to identify those mothers who have a high-risk pregnancy or some type of abnormality that might result in a major complication at the time of delivery, allowing a selected number of patients then to be referred to the available medical facilities. When you go out on the road as a military surgeon, you'll find old friends, but you'll find that there are resource-constrained environments, and these are places where ultrasound does quite well. Just talked to Dr. DeBose, who's coming back from a field trip, and he was saying that in his location, which he couldn't tell me, doing what he was doing, which he couldn't explain, he could say that they had ultrasound, and they actually had an emergency medicine physician who'd done a year fellowship in ultrasound imaging, and they were quite capable of making all sorts of point-of-care diagnoses. Talked to Dr. Pevick. Dr. Pevick showed me some slides. I think this is him right behind that fifth yak. This is Dr. Pevick on a trek in Nepal to the base camp of Mount Everest. You might have heard of it. But while on the trip, they did a number of experiments and observations about things like lung water, using ultrasound, using a portable ultrasound. So as a research tool, you could do things in the field that you might not be able to do. Turns out that Dr. Pevick is really strong, but when he thought about carrying a CT scanner or a fluoroscopic C-arm in his pack, he wasn't all that keen on that. Another remote location, Dr. Pevick said, I used to work for NASA, and that's true. There is a human research facility in the U.S. laboratory module on the International Space Station. It has fixed ultrasound, and it has a variety of research uses. But we've also, at least in the time I was at NASA, looking at a lot of different ultrasound applications for potential medical diagnosis, including things like, can you do things like a fast exam? Well, can you do it in microgravity where you don't have dependent fluid collections, and what happens to organ relationships? And can you do it when things are moving around? And so rather than fly it on a space shuttle or a space station, which is kind of expensive, we flew it in an airplane. And if you fly an airplane in parabolic flight, you can get about 30 seconds of microgravity at a time. And I think I have just shy of about a day of microgravity exposure, 30 seconds at a time. The 30 seconds of microgravity is followed by a 2G pullout, which is really where most of the folks who don't have a lot of time in the airplane find it provocative. It's actually kind of fun. I recommend it if you get the chance. But you'll see some interesting things. Blood doesn't spread out in microgravity. It forms fluid domes when it interfaces with air. And we did some laparoscopic studies to find out how intracavitary fluid moved about with pneumoperitoneum. We couldn't find human volunteers, so we did use an anesthetized swine model. And the laparoscopic studies include some other things like physiology of CPR, which is hard to do kneeling, but it's really easy to do with your feet on the ceiling. And ultrasound studies where we took relatively large ultrasound units and flew them on the KC-135. And this is our dedicated radiologist. He found that 2G pullout to be particularly provocative, but he continued to scan and collect data. Well, a couple of things as we shift away from kind of these interesting applications to what are we going to do here at UC Davis, or what are we going to do as part of our training to help people prepare to be ultrasound users. Well, we've done a few things in response to, in part to perceived needs and in part to new requirements that exist. And so in vascular surgery, there is a curriculum requirement for the vascular lab for residents and fellows. And now vascular laboratories for resident teaching have to be accredited. And accreditation in our lab actually requires that the physicians have a certificate that shows that they are qualified. The certificate that we use is called the physician registered physician in vascular interpretation, or RPVI. This has been around for just over a decade, and it's a physician-specific vascular ultrasound credential. It requires that you have a certain amount of prerequisite training and experience, do at least 500 ultrasound interpretations, and be a licensed physician, and then you take an exam. But it's an important enough thing that the Vascular Surgery Board, the American Board of Surgery, has said it's a prerequisite to getting board certified in vascular surgery. So if you're a general surgeon, you know you got to have certain things, certain boxes checked off, including things like ATLS. If you're a vascular surgeon, you have to have certain boxes checked off, including having this credential. So to meet that, we actually have, at UC Davis, developed a vascular lab curriculum where we have different components taught, foundational knowledge, is didactic instruction online, practical experience in the vascular lab, and learners meet specific milestones. And it turns out this curriculum has worked out fairly well for us, and it's now been adopted or adapted by other vascular surgery programs. We also export our teaching a little bit to not just our trainees, but also through continuing medical education. The Vascular Center has offered a multidisciplinary program, the vascular care program, for about 10 years, or for actually precisely 10 years. And we also do vascular lab focused programs. And so we've had over 1,000 learners and more than 100 different educators and presenters who have been part of these programs. And so it turns out that UC Davis is one of the places that people go to learn about vascular ultrasound. One of the early vascular ultrasound programs was started 30 years ago, 29 years ago now, it'll be 30 years next year, by Dr. Strandis, who I mentioned earlier, kind of the father of vascular ultrasound and the inventor of duplex scanning. And since 2011, UC Davis Office of CME has accredited that CME. And I bring this up because the next vascular care meeting is in combination with the 2017 offering, the 30th year of the Strandis Symposium. And if you are a resident or fellow, we invite you to submit an abstract for presentation, and that might be something that would appeal to people who have an interest in ultrasound or vascular therapeutics. I'd like to highlight a couple of contributions that UC Davis residents, faculty, and staff have made. About a quarter of the contributors to the current standard textbook in the field are from UC Davis contributors. And I talked about that PVI examination. And over the last 3 years, UC Davis volunteers have actually created the majority of the new items for that test. So people are being tested not just on their vascular ultrasound knowledge, but the way we think about it, I guess. So thanks to these folks who are part of our teaching faculty at David Grant, at the VA, and here. If you are a credentialed provider at UC Davis, how do you get ultrasound credentials? And it turns out that at the present time, each department has its own department level privilege delineation, but it's anticipated the health system is going to introduce some standards for people to get point of care ultrasound credentials to do patient care at UC Davis. And if you haven't heard about it, you should know that there is user training at UC Davis that you can get online through CME California, and hands-on training at the Center for Health and Technology. And also there are some new avenues for user proficiency certification that will be available in 2017 through the same folks that do the certification, the RPVI that I talked about. You can find other resources. You can find UC Davis surgical educators. You can find American College of Surgeons course. You can go online. Actually, there's a lot of good information about point of care ultrasound from commercial and non-commercial sources. So I recommend that you do a little bit of surfing if you're interested in learning more. We're not so sure about simulation. Certainly simulators are good for some basic sonographic skills, but it's actually fairly easy to do it with a human volunteer, and that's where a lot of the simulation actually gets done for point of care and other basic scanning training. Image-guided procedures are a little bit harder on volunteers, so that typically involves either a simulator or a phantom. And then there's going to be an increasing role for teaching interpretation in non-clinical settings as well. One of the things that's prevented point-of-care ultrasound from being widely used here at the medical center is the image management challenge. We have to have images that we can get access to for patient care and, of course, for reporting and quality assurance. But, of course, how are you going to get the machine paid for if you can't show a financial benefit to the institution? So we have to be able to bill. You can't do that without image management. And right now, it's kind of hard to put those on our PACS system, our picture archiving and communication system. We got a couple of traditional methods for point-of-care ultrasound. You could print it on a video image printer, little rolls of thermal paper. You can put it on a thumb drive. People take pictures with their iPhone of the screen, and that's okay, but it's not great. And there's a whole other variety of different things, including just not saving anything. So what UC Davis has done is there is a program that's been acquired. It's going to be first rolled out in the emergency room called QPath to be able to create an exam and reports and transfer these images and the report to the EMR and then send images to the PACS. Because of some of the network connectivity issues, it's going to take a little while to be implemented, but we're hoping to see that not only in the ER, but in our clinic within the next year. So I'll just summarize by saying a couple of things. First of all, surgeons, you guys, have a legacy of its role of being key players in the development of medical ultrasound and use of ultrasound to guide surgical therapy. I think most people recognize that point-of-care ultrasound is here to stay and is going to have an increased role in clinical practice. And you're going to be hearing more about education and accreditation and certification issues to help improve the consistency of these examinations and the reliability of the information that we get from them. And I think it's worthwhile understanding that you come from an institution where there have been some substantial contributions to the field and initiatives that have made impact in education of providers about ultrasound and patient care. So I thank you for your attention. I welcome your comments and questions.
That's a wonderful summary, Dr. Dawson. Any questions from the audience? I'll start then with this. What do you think about DARPA and they're looking for transformational changes? What might be another transformational change in body imaging? Is ultrasound it, or is there something else that's coming?
Well, I think some of the recently funded DARPA initiatives had to do with methods for diagnosis of neural injury, traumatic brain injury. There are a variety of other DARPA initiatives that have to do with health or medicine, pathogen detection, personnel protection. But in terms of imaging, I don't know of any big DARPA-funded initiatives. I think what happened in the 1990s is ultrasound was starting to be defined as a useful tool for managing surgical disease. And that led to the conclusion that having ultrasound capabilities in the field would add potential advantages. And so that generated some DARPA support.
Dave, what about the stuff that's going on at Livermore? The hyperspectral imaging, the visual wavelength stuff with...
Yeah, good. So hyperspectral imaging is the question. So hyperspectral imaging refers to taking a picture of something, but not just looking at the visible spectrum. And there's a lot of either transmitted or reflected energies throughout the spectrum that can be analyzed. Hyperspectral imaging started out as a satellite surveillance technology because you wanted to see where the Russians had dug in to put a missile launcher, or where there was stuff going on, and you couldn't see it, but you could see changes in the earth or changes in the texture. It's kind of like the dolphin finding something in the muddy harbor bottom. Hyperspectral imaging has been used in medicine to look at perfusion and tissue viability, but I don't know of any clinical applications that have come out. We first kind of used some hyperspectral imagers in the lab 10, 15 years ago, so it's been around for a while.
It's
Ultrasound.
Yeah.
Yes. Yes.
And you can also not only identify fractures, but you can see screws, see how deep the tip of the screw is, see K-wires as you are drilling them into the bones, and all kinds of paper stuff on that as well.
So musculoskeletal ultrasound is become a field of its own. And musculoskeletal ultrasound is something that is well suited to point of care because it's used not just by ultrasonographers who are making a diagnosis in the radiology department, but it's used by physical therapists, physiatrists, nurse practitioners, PAs, chiropractors, and there's pathways for certification for point of care ultrasound use that currently exist. So there's really quite a lot, and it's one of those things where I'd kind of said, oh, the bone and the lung are the things you can't see, and that's exactly what other people want to look at, the bones and the lung, and they see a lot.
Dave, have you ever used this for localization of embedded radio translucent glass in a lung? Glass is really tough to get out if it's not just on the surface.
Yeah, that was actually one of the first described applications of ultrasound for surgery as the ability to detect foreign bodies, and that was described. My own experience with it has been mixed, and that when there's tissue disruption of tissue planes, sometimes a little harder to find stuff. But if you ultrasound enough and you put your finger in the hole and you cut your finger, that's where you put the ultrasound.
Hey, one of the you're very up to date on the use of ultrasound in advanced areas. One of the techniques, again at the University of Washington, that was developed was focusing the ultrasound probes that it would generate heat on tissues of various depth with the idea that you could coagulate tissues or fry tissue deeply. What's happened to that technology?
High intensity focused ultrasound, or HIFU. HIFU is not a Japanese restaurant. It was something that's been around a while, and there are MR guided HIFU and other applications. The advantage of HIFU is you can potentially use the same system for imaging and treatment. So it's kind of a neat concept. But one of the problems with HIFU is that even though it's focused, there's a fair amount of thermal spread. And so when you're going through intact tissue, you're going through the skin, you don't necessarily get a very refined zone of energy delivery. So that's probably been one of the bugaboos. But with different types of beam focusing and different types of evaluation of the physical changes in the tissue, we might see something coming out of that. So it's definitely not a dead concept. It just hasn't evolved to the point of safe clinical applications.
Probably was a decade ago or 7, 8 years ago. I worked with a guy named Martin, the bioengineer from UW, who had DARPA funding to develop high-frequency ultrasound. We did a lot of animal experiments trying to coagulate things.
And you can coagulate things.
Deep in tissue.
Deep in tissue.
Yeah.
And some tissue around it.
Yeah, but I haven't heard anything about it in
Yeah.
the last while, so I don't know
It's still being used in research settings.
Is it?
Absolutely.
I have a very practical question. Let's imagine that I'm a surgeon at the University of California, Davis.
It's not a leap.
Yeah. And I am actually very interested in learning how to be actually competent at doing ultrasound, to look at fluid stats by looking at the indicator, to look for pneumothoraces, pleural effusions, to do the chest, to do a fast examination, and potentially to use it to guide access. And I don't just want to go on YouTube. I don't want to just take some online course. I actually want to get some instruction and be competent. How would I do that? Is there a mechanism to really get good at it, short of going away for a year someplace else?
So there's a lot of ways you can learn about pieces and parts of point of care ultrasound. First of all, you have to understand some basics of ultrasound. So you already know how to find the on switch, how to change the depth, change the gain, choose a transducer. Well, some people need that help. You already know how to manipulate some images in some very basic ways. You already kind of understand maybe that low frequency ultrasound is better for deeper structures but has less resolution. High frequency ultrasound is very good for superficial structures but less depth penetration. So you already have those concepts. So first thing, if you don't have those concepts, is some basic ultrasound education. And that is some foundational knowledge. And the American College of Surgeons has a course for you as a practicing surgeon or for residents that I think is a good start. In terms of specific applications, you can go to a course, and there's plenty of courses there, sometimes at the Clinical Congress, sometimes by other professional associations, American College of Emergency Physicians is very involved in that. And you can learn a skill, then you have to practice it and keep track of your score. Okay, so if you only do things, don't save pictures, don't keep records, don't look at your actual effectiveness, you won't improve. So you have to have some foundational knowledge, you have to have some education, mentoring, and training, and you have some clinical practice. But it turns out that for a particular task, the number of iterations that you would need is quite achievable. And I don't think I've seen anything that suggests you need more than 25 scans to be able to get to at least a basic competency in that particular application. Yes, ma'am.
One of the best courses that I took was women right before the SCCM, and I would wholeheartedly recommend it. 2 days, and it goes over all of the things that you talked about. And they have models and everything, so you were looking at it on real people.
Yeah, so what's happening is exactly what you've suggested, is that the game is being upped. Is that there is a broader recognition that people do need that training, and they do need a way to test themselves, and they do need a way to kind of keep track of who has that foundational knowledge and basic skill set to be able to practice. And that's probably one of the things you'll see a lot of changes in our world in the next few years as it kind of matures, it becomes mainstream. Not regulated. It's not going to be like a high-stakes exam, but someone's going to be keeping track. Thanks very much.
All right, very good, thanks.